Thank you, sir. Thank you. A very good afternoon to one and all. And speaking after Krishna is incredibly difficult, but I'm going to try and talk on Ozempic, which is a semaglutide 1 milligram dose, which is approved in the management of diabetes. And I'll also show you the label update for the organ protection that we have from the available data that we have with 1 milligram semaglutide, which is a weekly injectable therapy, which came into the Indian market in December last year, and which has been in the United States for the past, and other countries for the past 10 years. So we have robust data on semaglutide, and I'm going to talk about the data that we have with glycemic control, the weight loss that is seen in patients with diabetes with a 1 milligram dose. I'll show you the SELECT and the FLOW trial. Both were done with 1 milligram of semaglutide in the cardiovascular realm and the renal progression. And we'll also show you the label updates of how do you place this drug in your practice for the patients with diabetes. So this is my financial disclosure for this afternoon. So now we have definitely moved on. Diabetes is not an isolated disease. I think Krishna has made this very clear that it is CKLM syndrome where liver plays a very important role, and the association of diabetes and obesity is studied in CKD, cardiovascular disease, PAD, and also MASH. And management, we no longer just look at the numbers, we treat patient holistically, and we try to give them the drug, not just looking at the glycemic control. So it requires holistic, multifactorial, a person-centric approach is what we require in the management of diabetes, and this is very, very important. And what is Ozempic? Ozempic is semaglutide, which is a human GLP analog. It has 94% homology to endogenous GLP. I think this wording is very important. I think this is done after all the new generics that is now available in the market. Novo Nordisk semaglutide, right, is the molecule that has been extensively studied across RCT and RWE. And this is the update or the label that we have, or when we offer this to our patients, not just for glycemic control. So it has a half-life of about 7 days, suitable for once weekly dosing. And we know the oral formulation. And if you have listened to the pre-lunch session by Samit, how he described the difference between the original versus the coming soon oral semaglutide is completely different, totally different how it is sort of manufactured. Semaglutide in the oral formulation is co-formulated with SNAC, which we've been using for the past 3-4 years now, and it enables the oral dosing, and we have data from that as well. And this is probably the most important slide of my presentation. I have about 12 minutes, but this exactly tells you the evidence that we have with these molecules. When I use a drug to a patient, I think about the evidence. I think about what sort of outcome that I'm going to offer to my patients. And this is the robust clinical development program that has been done by Novo. The one that is just highlighted in squares are the phase 3A efficacy and safety trials. The one in orange are the completed phase 3B studies, efficacy studies and safety trials. And the one in blue or the green is a cardiovascular outcome trial, which is the SELECT trial. The SUSTAIN 6 trial, and also the FLOW trial, which is the renal outcome data with injectable semaglutide. And this gives you the total number of participants. I'm not going to walk you through this busy slide here. I have a more simplified version that I've borrowed from Dr. Singh in the next slide. But this just tells you the data that we have when we use this molecule for our patients. In number of patients being 20,000 being studied in India has also contributed to multiple these of phase 3A and phase 3B trials with oral 17 trials that have been studied. And what we know from all these trials is a powerful glycemic control, about 8 kilos weight loss, the compelling weight loss, the cardio-renal protection from SUSTAIN and the FLOW trial with once weekly dosing convenience, the cost of which is now significantly come down, which is also sort of affordable for our patients. So what is its impact on diabetes and the scale? So if you look at all these trials, again, a very busy slide, whether you use it as a monotherapy or you compare it with other OADs being sitagliptin or canagliflozin, one of the nicest SGLT2 that we've used in our practice, other GLP, exenatide, dulaglutide or liraglutide, both the doses, semaglutide at 0.5 and 1. That's why you have this light blue and the dark blue color that you can see in the bars shows a greater HbA1c reduction. Again, I have a better slide to show this. Here, this is what I borrowed from Dr. Singh sir. So if you look at the active comparators in patients with diabetes, looking at all the sustained programs, it also tells you the week that they've been studied, and also Japan and the China study, and the active comparator. The LIRA is 1.2 because it's a European study and it's not 1.8. You see the HbA1c reduction, and he's also given you a very easy way of looking at how SEMA is being a winner. In terms of body weight vis-a-vis the difference between dulaglutide, Cana 300, again showing you the semaglutide sort of flash. So this is sort of put together all the trials with semaglutide 1 milligram, which is the Ozempic dose, with the active comparators in patients with diabetes, with or without obesity, showing you in terms of the HbA1c reduction and the body weight reduction, we have a semaglutide sort of favoring with the other active comparators. So the HbA1c that is shown to be seen in these trials is close to 2.8%, which is about 4 out of your patients with diabetes, type 2 diabetes, would reach an HbA1c target. And this is something that we've all seen using this molecule for the past 3 months or even 6 months when Wegovy first was launched before Ozempic in the market, showing a superior HbA1c reduction. This is something that we really see in our practice. And if you look at the weight loss, which I again showed you in the previous slides, be it in monotherapy or vis-a-vis the other OADs, comparator with GLP-1 or add-on to SGLT2, be it basal insulin or basal bolus insulin, again showing you that greater weight loss was achieved with comparators. So you have a good HbA1c reduction with a weight loss benefit, with about 8 kilogram is what they have seen proven to be superior. So sort of addressing not just the diabetes but also the weight in patients with diabetes, sort of addressing diabesity, showing 3 out of your 4 patients would achieve a clinically meaningful weight loss. And Krishna talked about the benefit of weight loss from the various perspectives. So I'm not going to talk about that. And in terms of the organ protection, so what data do we have? We have the cardio-renal evidence with Ozempic. The SUSTAIN 6 is the CVOT trial with semaglutide. FLOW is the kidney outcome trial with semaglutide. Both of these were done with 1 milligram weekly dose. These are different from the STEP program and the SELECT program that Krishna showed you in his presentation, more from the obesity perspective. This is in patients with diabetes. And I'm not going to again show you the full walkthrough of this slide, but what is sort of important in clinical practice is both Ozempic at 0.5 milligram dose was also studied in the CVOT trial, showing a superior. So 1 milligram is a dose, but this is one CVOT trial. You will probably not see it in the other CVOT trials. Even in the mid dose, we start with 0.25 and then we go to 0.5 and then we escalate to 1. If you want the weight loss benefits, you go up to 1.7 and 2.4. So here, even the 0.5 dose was compared with placebo. So you see this is again unique to this trial, which is sort of very important. And if you have patients who are doing very well with 0.5 and you don't want to escalate to 1 milligram, it's absolutely okay, because there is a CVOT trial, or the CVOT trial, the SUSTAIN trial, looked into the 0.5 dosing as well versus the placebo. And basically they looked at the 3P MACE in terms of what happens. So this is the inclusion criteria, but I think this is sort of more clinically relevant. None of us are going to remember these numbers, the participants, the inclusion criteria, but this is sort of practically important for our clinical practice. And what it showed is, in the standard of care in patients who were already on a very good regimen, you had about 26% lower reduction of 3P MACE when compared to placebo in the SUSTAIN program, which is a CVOT trial with injectable 1 milligram semaglutide. And just to sort of walk you back again here, they have put the oral form, the Ribelsis. We know the SOUL trial which came out with Ribelsis, and this is something new. I know I'm not going to again walk you through the MACE reduction because none of us are going to remember these percentages tomorrow. Even I wouldn't remember. But this is the label update which just came out this year in January, that's 2 months back. So even with the oral Ribelsis, if you have a primary prevention, we know from the SOUL trial, the cardiovascular 3P MACE reduction. So we have now the prevention of first major cardiovascular. I'm talking about primary prevention label update that came out in January. Again, this is sort of clinically relevant to our practice, which I thought is very important to sort of talk for the audience today. And we'll move on to the FLOW trial, which is a renal outcome trial with again 1 milligram of semaglutide, Ozempic, adults patients with CKD, These were the inclusion criteria. One thing that is important for clinical practice is they were on RAS blockade, MRAs, and SGLT2. You know, the three major pillars that we talk about, and the fourth pillar now that we have strongly used now in our practice, endorsed by nephrologists and also by us in the mode of prevention, is GLP-1. Again, here it was studied in patients with placebo on the existing strong pillar of care with RAS blockade, MRAs and SGLT2, looking at the primary and the key secondary outcomes. And what it showed was a reduction in the 24% renal composite risk reduction in terms of progression of the renal disease. And how does this sort of look in terms of reduction of albuminuria? It's a 32% reduction in the UACR when compared to placebo. And this is sort of more important. So if you use this, or if I start my patients on Ozempic early on in the management, right? I don't have to wait for the CKD to set in. So, or if the patients, if you start them with the CKD stage 2 or 3, you're going to have a 65% slower loss of kidney function, which is amazing. You put in SGLT2 here, you put in MRAs, you put in the RAS blockade, you can prevent your patient to going into dialysis or waiting for the renal transplantation. I think that to me is a big thing, right? Protecting the kidneys, preventing the patients from progressing to renal replacement therapy or transplantation is a bigger achievement for all of us, and proven to delay kidney failure about 5 years. And this is why, you know, we have these drugs and we're talking about these drugs today. And in terms of saving lives, so you have about a reduction in the all-cause mortality about 20% and risk reduction of cardiovascular death by CV. So this sort of gives you a snapshot, and I think this is a very nice slide. So I have about 3 minutes left. So if you have a weight loss benefit about 8 kilogram for your patients with diabetes, a reduction in the all-cause mortality, you have 2.8% HbA1c reduction from all the data that we had, primary prevention of MACE from the SUSTAIN trial, MACE reduction, and from the FLOW trial, you also have the renal outcome trial, or the prevention or protection of the kidneys from deteriorating is what we are doing. So in terms of the broad label update for Ozempic, it is primarily as an adjunct to diet and exercise to improve glycemic control as a drug for type 2 diabetic patients. Additionally, I think this is what is important, and this is what sort of stands this out from the generic or the equivalent semaglutide that we have in the market. It reduces the major adverse cardiac events. If you have to use it for your patients to achieve this, then you have to use Ozempic to reduce the risk of sustained EGFR decline, end-stage kidney disease, and cardiovascular death in patients with diabetes. And this again I borrowed from Dr. Singh's Dr. A.K. Singh, sort of gives you all the trials that are sort of lifted out here. With the Ozempic, see again, doses of 0.5 is included. I think this is more clinically relevant for our practice, and I am okay if my patient's doing it 1.5 of semaglutide with excellent glycemic control, weight reduction. I'm still going to give them the cardiovascular benefits. That is from the data that we have from the SUSTAIN trial. So SUSTAIN 6 showing the CV benefits, the FLOW showing the kidney benefits to reduce the sustained EGFR decline. We have the oral Rybelsus in terms of the primary prevention label update from the January of this year. Wegovy is what Krishna mentioned in terms of the cardiovascular benefits from the obesity from the SELECT trial. The MASH, again, we don't have the label update in India, and that's why he said close your ears to Novo, but again, it is to approve to treat. Those are the true drugs that we have right now, the resmetirom and the semaglutide, to treat adults with MASH with moderate to advanced fibrosis and not with cirrhosis. This is from the ESSENCE trial. So this gives you the snapshot of the different portfolios that we have with semaglutide with 1 milligram, 2.4, I'm sorry, and the oral semaglutide, the Rybelsus. Again, all long term. I think this is a key slide from Novo Nordisk, which they are stressing here this afternoon, that all these long-term outcome trials that were done with CVD, CKD, the mortality benefits, and be it the STEP trial, the SELECT trial, the ESSENCE trial with the semaglutide at higher doses, were done with original rDNA semaglutide, the recombinant one, the Ozempic and the Rybelsus and the Wegovy. So to sort of here, if you have to combine all these things to put together into the last slide of my presentation, this is the original rDNA semaglutide ensures holistic diabetes care in terms of glycemic management, weight management of about 8 kilos, CV risk reduction from the SUSTAIN trial, the renal outcome from the FLOW trial, the CKD risk reduction, with the convenience of once weekly dosing, with the price reduction, which is sort of affordable for our patients, used by over 28 million across the globe, with the robust data that we have over 10 years of data and the use that we have with semaglutide. And with this, I finish and I thank the organizers and Novo for giving me this opportunity. Thank you.